Hi everybody, this voiceover is going to be Module 6, Part 1, Problems of Oxygenation and Ventilation. So we covered this a little bit last week, but let's talk about the difference between SpO2 and PaO2. SpO2 is when we put a pulse ox on our fingers, toes, earlobes, forehead, even the bridge of the nose, and it's going to measure the amount of oxygen saturation of hemoglobin. And of course, 95 to 100 is normal. Now, PaO2 is partial pressure of oxygen, and this is part of our arterial blood gas result. 80 to 100 millimeters of mercury is normal, and it actually measures the oxygen in the blood. And so when we get below that 80, we have hypoxemia for the patient. And hypoxemia is abnormally low concentration of oxygen in the blood. So sometimes we haven't gotten the SpO2 or the ABG, so we need to be able to identify signs of hypoxemia. And so early signs are changes in mental status, such as restlessness, confusion, agitation. So you might have a patient who's constantly picking at things, maybe picking at their gown or pulling their oxygen off. And those are often early signs, and one of our very first interventions with that is going to be checking that SpO2. Because our brain is so sensitive to those oxygen changes, we're going to see that early. Now, signs of respiratory distress. As a nurse, it is imperative that you can identify signs of respiratory distress. So the patients may have tachycardia, and that's because the heart is identifying that there's not enough oxygen, so it's trying to beat faster to get more oxygen there. Or tachypnea, or increased respiratory rate. Dyspnea, so that shortness of breath. Diaphoresis, which is that sweating. There can be mild hypertension, again, because the heart is working a little harder. Now, cyanosis is a late sign of hypoxemia, and it really doesn't occur until our PaO2 is less than 45. So we don't want to wait until somebody is cyanotic to be intervening. Along with these signs of respiratory distress, we're going to notice increased work of breathing, so they're using accessory muscles or respiratory muscles. Nasal flaring is a red flag in a baby, showing that they are in distress. Fatigue, inability to speak in a complete sentence is also a huge red flag for somebody who's in distress. Stridor, as we've talked about previously, stridor is that upper airway, kind of that wheezing sound. But anytime you have upper airway stridor, that's a medical emergency as well. Paradoxical chest or abdominal movements, when the breathing, the chest and wall abdomen moves in on inspiration and out on expiration, in reverse of our normal movements that we would see. And the tripod position, we'll talk more about this with COPD patients, but that also usually is a way that somebody automatically tries to compensate when they're having difficulty. And then, of course, when we're auscultating somebody with hypoxemia, we may hear anywhere from crackles, wheezes, decreased breath sounds, or even no air movement, or even a pleural rub. It's going to depend on what that underlying cause is as to what we will hear. So again, respiratory distress. Similar symptoms as those hypoxemia, tachycardia, tachypnea, that shortness of breath, that dyspnea, diaphoresis, mild hypertension. We talked about that cyanosis is a late sign. Again, using those accessory muscles, nasal flaring, inability to speak in complete sentences, stridor, and retractions, and we'll talk more about retractions later on. Those are all signs of somebody who's really having a hard time breathing. Fatigue is common too, but not necessarily going to be those red flags that if I see those things, I'm going to be watching for. So next we're going to talk a little bit about nasal trauma. So I added a couple pictures on here. What you see in that top picture up here with those bilateral ecchymosis of the eyes, that is also known as raccoon sign. Now that happens when somebody kind of get hit in that face. It's actually known when somebody has a basilar skull fracture. And if you think of the anatomy, right back behind the eyes, there is a very narrow skull bone, the basilar skull. And when that has a fracture, we will normally see that periorbital ecchymosis. The risk for that is that because it's so close to the brain, is that somebody could end up with a cerebral spinal fluid leak. And when we think about our cerebral spinal fluid, you think about how it's really important that that stays sterile, and if something is able to get out, then other things can get in. So one of the ways that we would suspect a cerebral spinal fluid leak is when somebody has clear or persistent pink drainage, and this is usually coming from the nose or the ear. And what we can do is test that fluid and we can look for that halo sign, which is what this picture down here is. Taking that pink fluid here and you get that halo around that. That is showing that there is glucose in it. You can also test it for glucose. And one of the reasons I think about this is that, you know, our mucus does not have sugar in it. If it did, little kids would not stop eating their boogers. So having glucose in our nasal drainage is something that we see with cerebral spinal fluid leak. So if we do have somebody who has a cerebral spinal fluid leak, we would need to report that to the healthcare provider. The periorbital ecchymosis also could indicate that cerebral spinal fluid leak with the basilar skull fracture. And with that, they actually cannot just do an x-ray because that bone is so thin. They actually have to do a CT scan to look for that basilar skull fracture. So with that nasal trauma, obviously there can be deformity if there's a broken bone in there, nosebleed, pain, crepitus, that little crunching sound, swelling, difficulty breathing through the nose, and ecchymosis. Now, those signs and symptoms themselves are not a medical emergency. Just because I have difficulty breathing through my nose, I still have the ability to breathe through my mouth. So it's not an airway issue. Now, care for somebody who's had nasal trauma, we are going to be monitoring for patenaria, watching for that edema and pain, and if they have ecchymosis or epistaxis, we will need to stop that bleeding. You want to have the patient sit upright. You can actually apply ice to the face for that 10 to 20 minutes at a time. Acetaminophen for pain would be preferable versus NSAIDs or aspirin because those are going to increase bleeding. Decongestant nasal sprays can be used, but those have to be used sparingly. That would be like the Afrin, which has the neosynephrine in it, which helps to vasoconstrict things, so it makes it a little easier to breathe. Nasal ocean spray, which is just normal saline, can help with some of that nasal stuffiness. They want to avoid hot showers, and alcohol decrease the edema. Definitely no smoking for tissue healing. And then the healthcare provider will realign the fracture if there is one, where they can actually do that manually or with surgery. And if the nasal mucosa is disrupted, they may put them on an antibiotic. So let's talk about epistaxis, which is just our fancy name for nosebleed. So with nosebleeds, there can be many causes. People can have spontaneous bleeds, anterior bleeds, where we're talking about lower in the nose, more toward the nares. Those often resolve spontaneously. Posterior bleeds, where they're further back in the nasal passage, may require medical equipment. And so again, with the epistaxis, sitting position, leaning forward, never leaning the head back. That's just going to make the blood go down the back of the throat. Apply some direct pressure, squeezing the nose for 5 to 15 minutes. If that does not resolve it, they can use a Pledget, which basically right up here, this picture that I added, that's called a rhinorucket. Basically, it looks like a tampon, and they would put that in there to help stop the bleeding. They can also do this one down here, which is an epistaxis balloon. Same thing. It's going to help cause that pressure inside. If they have this posterior balloon back here blown up, you do have to worry about airway. So more with an anterior bleed, less of a risk for airway issues, but posterior bleeds, much higher risk for airway issues. And then they can also do chemical or thermal cauterization or embolization to stop the bleeding if it's severe. So again, nursing interventions, we're going to be monitoring our respiratory status, our level of consciousness, vital signs, pulse ox, watching for any dyspnea or dysphagia. Again, priority, that packing can slip and cause airway obstruction. Lots of times we'll administer some analgesia prior to inserting that. That is a pretty large amount of gauze that they're putting up there. Again, they might get antibiotics. And then we also pre-medicate before removing the packing. And usually that packing is in there 2 to 3 days. I have never personally removed the packing. Always an ENT doctor has removed that. Patient discharge instructions, again, that humidification or nasal spray that I talked about. They want to sneeze with their mouth open, which helps to decrease that pressure in the nose. Again, avoiding that aspirin and NSAIDs, and also avoiding vigorous nose bleeding, strenuous activity or lifting or straining for 4 to 6 weeks so that we don't cause that to rebleed. So rhinitis. This is just basically inflammation of the nasal mucosa, and most types of rhinitis are caused by an inflammation and are associated with symptoms in the ears, eyes, or throat. Can also include like runny nose, sneezing, or itching. Some other causes can be seasonal pollen, or it can be perennial, meaning it's all year long, and that can be environmental. And for me, I've always got a little bit of a runny nose. I'm not 100% sure what all of my allergies are, but I have it all year. And then, of course, when you have the seasonal, then I get worse in other times there too. So if you're actually looking into the nose, you might see pale, boggy, swollen turbinates, which are just part of the nares. Somebody may have some decreased smell, the nasal drainage. Chronic exposure, they can get headaches or nasal congestion, sinus pressure, hoarseness, cough due to nasal polyps, and postnasal drip. So management is going to try to identify and avoid those triggers. So triggers include dust, dust mites, pollen, mold, pet smoke. Medications that we can give would be corticosteroids, either nasal and or orally. And so nasally, I'm thinking of the Flonase. Orally, of course, would be like our prednisone. Antihistamine, that can either be first-generation antihistamines like Benadryl, which cause more drowsiness, or it could be second-generation antihistamines like cetirizine or loratadine. Leukotrienes, receptor agents, is a new class of medications. They help with asthma treatment. It's in a tablet form, and it helps, the mechanism of action for that helps to result in a combination of both bronchodilation and anti-inflammatory effects. And then immunotherapy, allergy shots may also be useful for some patients. Now, acute viral rhinopharyngitis. This is basically just our common cold, upper respiratory infection, although it's viral, so it's not truly an infection. So greater than 200 viruses, including the coronavirus, fall into this. It is highly contagious, airborne droplets or contact, more common in the winter months because of the close contact and closed windows. It's also influenced by fatigue, stress, allergies, and an altered immune status. And symptoms typically appear 2 to 3 days after the exposure, and symptoms are going to be the runny nose, watery eyes, nasal congestion, sneezing, coughing, sore throat, fever, headache, and fatigue. And I felt like I was just doing a medication ad on TV. And people generally recover in 7 to 10 days. So again, notice how I have on this slide that the viral is bolded. So management, it's symptom relief. We're going to do plenty of rest, plenty of fluids, antipyretics if they have a fever, analgesia, saline spray for the nose, gargling lozenges. Again, the antihistamines, decongestants. We really don't want to be doing those nasal decongestants more than 3 days because of the rebound in the nose. Potentially cough suppressants, and then vitamin C, echinacea, and zinc can all help that to go away a little quicker. And notice that there is not antibiotics unless there's complications indicating bacterial. This is a very classic thing that students miss on exams. What would you do for acute viral rhinopharyngitis? Remember, virus, we're not giving antibiotics. We are going to teach them to report secondary infection or worsening of symptoms, chronic diseases. So somebody with COPD or asthma, they're going to want to report their sputum changes, shortness of breath, chest tightness. And of course, with any kind of thing, we want to teach people to avoid crowds or sick people and use good hand hygiene. So influenza. You all know that the flu is highly contagious. There is an increased morbidity and mortality with it. Peak season is December to February. Influenza A is the most common and virulent. There are lots of mutated viruses. Pandemics is when we have it worldwide. Epidemics is localized. Transmission 1 day before onset symptoms, up to 5 to 7 days. Signs, it's usually an abrupt onset. Chills, fever, myalgias, those muscle aches are really classic with the flu. Headache, cough, sore throat, and fatigue. Complications can progress to pneumonia, ear, sinus infections, and older adults tend to be more weak and lethargic. Influenza B, just as note, is more common in children. So again, best practice management for influenza, prevention is our best management, and that's through our annual vaccinations. They can either get inactivated or live attenuated vaccines, and that will determine based on whether or not they are able to get live viruses or not. It does take 2 weeks for antibody production, and we really want to advocate for the vaccine for people who are greater than 6 months, who are high risk. We also want to encourage healthcare workers and long-term residents to get the flu vaccine. And it's mostly all about symptom relief and preventing the secondary infections. So again, it's that rest, fluid, antipyretic, and analgesics. They do sometimes give the antivirals. So the oseltamivir, and I know I butchered that one, the Tamiflu is the trade name, pill is commonly given. It does help to shorten the duration of the symptoms and decrease those risks for complications. So obviously airway obstruction is a medical emergency. We need to immediately assess and treat. Otherwise, people can end up with brain damage or death within 3 to 5 minutes. And an obstruction can be partial or complete. So signs of an airway obstruction would be choking, stridor, use of accessory muscles, suprasternal and intercostal retractions, nasal flaring, wheezing, restlessness, tachycardia, cyanosis, and changes in level of consciousness. In class, we'll listen to stridor and we'll look at some retractions and nasal flaring. Interventions to help maintain that or establish that patent airway: Heimlich maneuver, cricoid, thyroidectomy, ET tube intubation, or a tracheostomy. So tracheostomy, it's a surgically created stoma in the neck. It is used to establish a patent airway. It can be used to bypass an upper airway obstruction. It helps to facilitate secretion removal, especially for people who have a hard time getting that secretions up. For somebody who is on long-term mechanical ventilation, we usually do put a tracheostomy to protect their vocal cords, and it may help to facilitate weaning from mechanical ventilation. So they used to, pre-COVID, anybody who was intubated, they would want to do a trach within 2 weeks, and sometimes even a little earlier than that. During COVID, that changed a little bit, and because it took sometimes for 3 weeks for people to be able to be extubated, they were waiting for tracheostomies a little longer than they had been prior to our pre-COVID time. So tracheostomies can be done emergently, which is what that's called, that cricothyrotomy, and that is not a nursing scope of practice. Most of the ones we're taking care of in the hospital, they've been created surgically in the OR, or it can be done percutaneously at the bedside with somebody who is highly sedated in the ICU. So the tracheostomy, this is a review because I know that you learned about tracheostomy when you were learning about suctioning. So this is just how it looks when it's not inside the patient. So this is our flange. The outer cannula, there is the cuff that helps to keep it in place. There is a hollow inner cannula which goes in here. And the obturator is only used, it's inserted to the tracheostomy tube to help with placing the tube in the trachea. It helps to provide a smooth surface to guide the tube into the airway without damaging the inner lining of the trachea. But you have to remove that right away once you get it in there, because notice that it's got a rounded tip and there's no way for air to pass through this. So you will suffocate your patient if you leave that obturator in there. Now this pilot balloon here, that is what blows up your cuff, and you can actually look at this and tell if your cuff is inflated or not based on this balloon. And then of course there's tie strings, and there's a couple different ways that you can change those, and that's part of care. So again, once somebody has a tracheostomy, we do keep the obturator at the bedside. The cuff is inflated. We do confirm placement by auscultating for air entry, end-tidal CO2 or capnography, and the ability to pass the suction catheter and chest x-ray. Tracheostomy should be sutured in place and secured. And when we have that, we should be monitoring vital signs, SpO2, and if they have mechanical ventilator, those settings. So it's really important that when somebody has a tracheostomy that we work to prevent that from being dislodged. So we should be very careful when we're turning or repositioning the patient. Keep a replacement tube of equal and or smaller size at the bedside. So you always keep a whole nother set right there at the bedside. You do not change your tracheostomy tapes or ties for at least 24 hours after placement. And then the healthcare provider performs the first tube change, but not sooner than 7 days after it has been placed. So notice in this picture here, you can see these sutures. And so tracheostomies are most often sutured in place to help keep them from being dislodged. If it does become accidentally dislodged, though, you're going to make sure that the patient's able to breathe. You can use hemostats in the opening to help spread that tissue to allow them to be able to breathe. Call for help. If you have some help, you can put that obturator in that spare tracheostomy tube and actually lubricate it and re-put it back in place and then remove the obturator. Or you can use a suction catheter and thread that through the new tracheostomy tube over the catheter and then place it and then remove the suction catheter. If you can't insert a new trach tube, cover the stoma with sterile gauze and ventilate with a bag mouth mask. So our providing air support until you get that help. So when somebody has a tracheostomy, we have to do care to that. So we're monitoring for complications such as bleeding, airway obstruction, or infection. We should be assessing that site and patency every shift. Respiratory therapist will help us to monitor the cuff inflation and pressure. We should suction PRN. And because they are no longer breathing through the mouth, we need to add humidified air. That helps to thin the secretion and reduce the risk for mucus plugs. When we breathe through our mouth, that's where our moisture comes from. So that's why this person with trach needs to have that humidification air. Now there's a couple ways that we can suction. This is the open suction sterile technique, is what you learned in lab. This closed suction, this is really cool. It has a little plastic thing over it, and so they just wear regular gloves and they can stick that in there and pull it out, and this suctioning catheter stays sterile the entire time. And that's usually used when somebody is intubated in the ICU. They use those types of things. So again, tracheostomy care is going to be per your agency policy. You do change the ties generally at least every day. You're going to observe the tracheostomy site for signs and symptoms of infection. Tracheostomy care where we're actually cleaning that inner cannula. Sometimes we're actually just throwing away those plastic cannulas and putting a new one in. If they do have one of the old metal cannulas, we do clean those and reinsert those. Suctioning as needed. Remember, suctioning hurts, so we don't do that unless we have to. The tube should be changed monthly after the first tube change, then every 1 to 3 months. And that's actually talking about the part that is actually in their throat part. And then cleaning their trach is clean technique at home, not sterile technique. In the hospital, things are really germy, so we do sterile technique. So again, changing the ties, there's different ways that you can do it. Notice that this is, C is kind of the way that I like to do it. I take it through here, slip knot type of thing, and then bring this through, and then I tie it over here. That's if I have trach tape. But the Velcro ones are just so nice. They have much less problems with skin breakdown. But I have had patients whose necks were too big to use the trach tape, so we did have to use the actual, they couldn't use the Velcro, they had to use the trach tape. Of course, people who have trachs, they do have the risk for swallowing dysfunction. When the cuff is inflated, it does interfere with normal functioning of the muscles used to swallow. So we usually get a speech therapist that helps to do that clinical assessment for swallowing and aspiration risk. They can either do that through fluoroscopy or endoscopy evaluation. If there's no risk for aspiration, we leave the cuff deflated or replace with an uncuffed tube, and then they can have those thickened liquids or soft foods as allowed. Now, if they can't, then they may need to have tube feeding. Remember that somebody who has a trach is going to have some difficulty with communicating. So other ways that we can communicate with somebody is paper and pencil, a whiteboard, cell phone where they can text, magic slate, a picture board, a visual alphabet where they kind of point things, or text-to-speech applications. So once the patient has returned to spontaneously breathing, there are some things that can help promote speech. And one of the things is a Passy-Murray valve. And so this little valve goes over the opening of the trach, and that helps to block off air so that they can speak with it. With that, you must always have the cuff completely deflated, or else the patient's not going to be able to breathe. The cuff inside here is going to block the airway, and then you're blocking it here, and so they're just not going to be able to breathe. There are also fenestrated tracheotomy tubes where they have some openings in the outer cannula, which allows holes in that inner cannula, and that those holes help to direct some air towards the nose and mouth instead of just through the tracheostomy opening in the neck. And this allows the person to be able to make noises and speak. So one of these two things helps somebody to be able to speak. So decannulation, removing the trach out of somebody. On this slide, it says the epithelial tissue starts forming in 24 to 48 hours and the opening closes in 4 to 5 days. I did a little additional research because that seemed a little early to me, if somebody, especially if they've had a trach for a long time. And from some of the research, I saw that up to 14 days or even again longer for somebody who's had it a long time. Really depends on how long they had the trach. Now, criteria for somebody to get the trach off or the decannulation, obviously they have to be hemodynamically stable, they have to be able to breathe on their own, adequate gas exchange, and independently able to expectorate. I've had many patients who had really weak coughs and they could not get that mucus out, and so that was a reason for them to keep their trach. So prior to decannulation, we're obviously going to explain the procedure, monitoring our vital signs, suction the tracheostomy and mouth, remove any tapes or ties and remove sutures, deflate the cuff, and we just remove it in a nice smooth motion. So think about pulling an NG tube out or a Foley out. Similar, it's just going to be a nice smooth motion. After we actually decannulate, we will apply a sterile occlusive dressing, monitor for any bleeding, monitor our respiratory status, make sure that we have an alternate O2 device if we need it, and patient education about splinting that stoma when they are coughing, swallowing, or speaking until it has healed. All right, so now we're going to move on to acute bronchitis. Bronchitis is a self-limiting inflammation of the bronchi, mostly caused by viruses. Other triggers can be pollution, chemical inhalation, smoking, chronic sinusitis, and asthma. Symptoms tend to be cough with clear or purulent sputum, headache, fever, malaise, dyspnea, and chest pain. Diagnosis is based on assessment and breath sounds. Generally, we're going to hear crackles or wheezes. Treatment goal is symptom relief and preventing pneumonia, so it's going to be supportive. Cough suppressants or oral fluids and possibly humidifier. Beta-2 agonist inhalers, which beta-2 agonist inhalers would be like our albuterol. Those would be for wheezing or underlying pulmonary conditions. We want them to avoid irritants. If they have influenza, we want them to get antivirals within the 48 hours. And they should see the healthcare provider if they have fever, dyspnea, or duration greater than 4 weeks. Now, pneumonia is an acute infection of the lung parenchyma, associated with significant morbidity and mortality. Health promotion for pneumonia, we're going to teach hand hygiene, nutrition, rest, regular exercise, coughing and sneezing in our elbow instead of the hands, avoiding cigarette smoke, trying to avoid exposure to upper respiratory infections and getting prompt treatment for those. Identify the risk factors, and influenza and pneumococcal vaccines. So when somebody has pneumonia, there's that inflammatory response where we have that attraction of our neutrophils, those particular white count that is involved with bacteria. They're going to have release of inflammatory mediators and an accumulation of fibrous exudates and red blood cells and bacteria are going to occur. And this causes the alveoli to fill with fluid and debris, which is considered a consolidation. It can also increase production of mucus, causing an airway obstruction. Either one of these is going to cause a decrease in gas exchange. So with resolution of the infection, the macrophages and the alveoli help to ingest and remove the debris. Normal lung tissue is restored and gas exchange returns to normal. So there are several types of pneumonia classifications. Community-acquired pneumonia, also known as CAP, is an acute infection of patients who have not been hospitalized or resided in a long-term care facility within 14 days of the onset of the symptoms. Many times this community-acquired pneumonia can be treated at home or hospitalized dependent on patient's age. So it's going to depend based on their vital signs, their mental status, comorbidities, and conditions. Now, hospital-acquired infections are also known as nosocomial pneumonia. Those occur within 48 hours or longer after hospitalization and were not present at the time of admission. There's also ventilator-associated pneumonia, also known as VAP, and that occurs more than 48 hours after they've been endotracheally intubated. And that's why when we had kind of talked about this with our surgery patients, they're not ventilated that long, so that's usually not a type of pneumonia that they do get. So again, other types of pneumonia, viral is the most common, may be mild or life-threatening. Bacterial may require hospitalization. Mycoplasma is an atypical type. Aspiration, when somebody aspirates. Necrotizing, it's a rare complication of bacterial lung infections, often result from our community-acquired pneumonia. And then opportunistic, and this happens in our immunocompromised patients, such as those with HIV or those who are on immunosuppression drugs. So aspiration pneumonia, it's when there's an abnormal entry of oral or gastric material into the lower airway. Major risk factors are that decreased level of consciousness or that depressed cough or gag reflex, difficulty swallowing, insertion of nasogastric tubes with or without tube feeding. Aspiration of material triggers that inflammatory response. And then primary bacterial infection is the most common. Empiric therapy based on probable causative organism, the severity of the illness, and patient factors. And then aspiration of acid contents initially causes chemical or a non-infectious pneumonitis, which then results in a possible bacterial infection in 24 to 48 hours. So how can we help to prevent aspiration pneumonia? Head of the bed 30 degrees and have patients sit up for all meals. Assisting with eating, drinking, or taking meds as needed. Monitoring that gag reflex. Monitoring reflux and gastric residuals for somebody who has an NG tube or some sort of tube feeding, early mobilization, coughing and deep breathing and sinus barometer, and oral hygiene twice daily. And sadly in the hospital, I'm not even sure that's happening once a day. So what assessment findings are we going to have with somebody with pneumonia? Restlessness or lethargy. Again, that is often going to be secondary to the hypoxemia. Fever, chills, tachycardia, and with our older patients, they may actually even not have a fever. Very common for them to have hypothermia. Debilitated patients can have confusion or stupor. Respiratory findings, cough may be productive or non-productive. If it is productive, it could be green, yellow, or rust-colored sputum. There may be asymmetrical chest movements, use of accessory muscles, nasal flaring, dyspnea, tachypnea, pleuritic chest pain, and that is generally chest pain when somebody breathes in, fine or coarse crackles, and when there's consolidation, you may have bronchial breath sounds or egophony, and egophony is when there is a consolidation, a fluid-filled or compressed lung changes the way things sound, and so when you listen, this changes the sound of the vowel E, and it sounds like an A. Another symptom that you could see with consolidation is increased fremitus. And fremitus is when you're palpating the chest wall to detect changes in the intensity of vibration with certain spoken words. And so when they're saying it in the same tone and same voice, and then you're going to feel more fremitus at certain parts, that's going to also indicate that there's consolidation and a sign of pneumonia. So when we are looking for somebody with pneumonia, chest x-ray is going to be one of our first things. And I found this picture on the internet here, and it's kind of pointing. Normally a chest x-ray is nice and black like this. And so this white spot here is telling that this person has pneumonia. Also pulse oximetry, ABGs, again, only if we think that they're really bad. Sputum, gram stain, and culture for sensitivity. Ideally, we do that prior to antibiotics, but sometimes we don't get those as early as we'd like. Potentially check for blood cultures, and definitely doing a CBC with differential. And we're looking for that, whether they have that neutrophil shift or to determine if it's bacterial. So again, prior to somebody actually having pneumonia, we would want them to get the pneumococcal vaccines to help prevent that. Once we've diagnosed pneumonia, then we're going to anticipate antibiotics. So we're going to see a response pretty quickly within 48 to 72 hours. Hopefully we're going to see that decreased temperature, improved breathing, decreased chest discomfort. They may do repeat chest x-rays in 6 to 8 weeks if somebody is having this treated as an outpatient. In the hospital, we generally have them on IV antibiotics right away, and then we might switch them to a different medication later on. So when you think of your antibiotics, Remember, your mycins are always antibiotics, so whether that's gentamicin, streptomycin, I can't even think of all the different mycins, but mycin always tells you antibiotic. One of the most commons that I see given is ceftriaxone, also known as Rocephin. It's a broad-spectrum antibiotic. And then supportive care for pneumonia is going to be oxygen for hypoxemia, analgesics for chest pain. We're again going to try to stay away from those opioids if we can. Antipyretics for fever, and individualize the rest and activity based on the patient and how they're doing. Now, viral pneumonia, there's no definitive treatment. They may receive some antivirals. So nutrition for pneumonia. Always adequate hydration. Hydration helps the patient to thin their secretions and are able to get that out, so we're going to monitor intake. Want to prevent that dehydration. As I mentioned, it thins and loosens those secretions. And we have to adjust this for older adults or patients with heart failure or patients with pre-existing respiratory conditions. So some of those fluid things might be different for those patients. And as you'll hear me say all semester long, when you have a nutrition question, small, frequent, high-calorie, nutritious meals is always the answer. It is never 3 large meals. And then, of course, we would be monitoring their weight. And lastly, patient teaching. So patient teaching for home care, we're going to need to emphasize the need to take the full course of antibiotics. Adequate rest, adequate hydration, avoiding alcohol and smoking or even that secondhand smoke. They can use a cool mist humidifier or a warm bath. They may need additional chest x-rays and vaccinations once they are over this. And it takes several weeks or more to recover, again, depending on the patient's age and comorbid conditions.